Okay, in this section, we're going to cover Chapter 28, which is about the respiratory system. So this will give us a brief review on the anatomy and physiology of this particular system. So the things that we'll cover here are just kind of reviewing the structure and function of each of the organs in the respiratory system, both the upper and the lower respiratory system. It will review the events going on in both inspiration and expiration of air. We'll talk a little bit about the oxygen and carbon dioxide and how they're transported in the blood. And then we'll look at some of the volumes and capacities that we actually measure how that air is inspired and exhaled with each breath. And then at the end, there's a couple of slides to talk about the signs and symptoms of the common pathophysiologic or disease processes that we often see in the respiratory tract. Okay, so when we actually do a review of our organ systems, we have to look at the upper respiratory system as well as the lower respiratory system. And so we have to remember that our nose is actually considered our primary breather. That's where we really want the air to go through, okay? And the structure of and the anatomy of the nasal passages is actually designed to inhale air. One of the major areas in the nasal cavity is called the nasal conchae. You'll also see that called the nasal turbinates. And that is an area that has an excessively increased surface area within the nasal passage that allows for added warmth and moisture and humidity to that inspired air. And so although a lot of people do tend to breathe through their mouths, the nose is actually the structure that's designed to do that, okay? If people have nasal congestion or a cold or allergies, then they find themselves breathing more through their mouth. But the mouth is not designed to warm the air or moisturize the air, and so that's why the nose is the specific area that's designed for that, okay? Another structure that we look at within the upper respiratory tract are the paranasal sinuses. And we have 4 different sets of sinuses. We have the maxillary, the frontal, the ethmoid, and the sphenoid. And their functions, they have kind of a multitude of functions. They are air-filled spaces that are within the skull bones, and they do open up into the nasal cavity. They do help to lighten the weight of the skull, but they also act to equalize pressure between the skull and the outside environment. And so we'll talk a little later about what a sinus infection is, but if anybody's ever had one, when those sinuses have excessive mucus and or bacterial buildup, it can actually be very uncomfortable. You can get lots of postnasal drip and colored discharge, and it can give headaches. And so the sinuses being open and patent is very important for the working structure of the skull, okay? Then as we travel back, we go into the pharynx. Now the pharynx is actually another word for the throat. And the throat is divided, that area is actually divided into 3 sections. The pharynx itself is actually both part of the respiratory and the digestive tract because air goes down that area through the lungs, but also food and liquid passes through part of this pharynx system as well. So the pharynx is actually both respiratory, involved in both the respiratory and digestive system. In and of itself, it is divided into 3 sections. There is a nasopharynx, an oropharynx, and a laryngopharynx. The nasopharynx is indicating that it's near or behind the nose. And so that's the initial top part of the pharynx area where air is designed to go through, okay? Then the area that we actually open up when we say ah and directly see, that's the oropharynx. Oro is referring to oral or mouth. And then if you travel down a little farther, we have the laryngopharynx, and that's where we actually have the vocal cords and the voice box, okay? Now that larynx area of the vocal cords sits kind of on top of or superior to and is continuous with the transition to the lower respiratory tract, which is the trachea. The other word for the trachea is called the windpipe, okay? And so that larynx area contains the vocal cords, also called the vocal or the voice box. And below that, there's a little flap that sits on top of that area that actually will open and close off that area so that we don't actually inhale food or liquid when we are eating and drinking. So that epiglottis is that flap-like structure that closes the larynx off. So that when we eat and drink, we go down the esophagus, but then when we need to take a breath, then it opens up and relaxes and let air travel in from the larynx to the trachea, which is the upper part of the lower respiratory tract. Okay, so from the larynx or the voice box, we have that little flap that covers it. Then that flap opens up into the trachea. The trachea is also called the windpipe. That's the largest branch-like structure of our respiratory tree. And it's sort of the trunk of the tree, if you can imagine our respiratory tree being upside down, with the trunk being at the top and with the leaves and the small branches being at the very end. The windpipe is a long tubular organ, and it extends from the larynx to the primary bronchi on each side. Okay, it has a special layer inside of it called the mucociliary escalator. And that mucociliary escalator has a mucus layer and cilia, or very, very, very small hairs that actually constantly and consistently beat upward to make sure that microbes and dust and debris don't get down into the smaller areas of the lower respiratory tract, the bronchi, the bronchioles, and the alveoli. If something affects that mucociliary escalator and it doesn't work properly or doesn't work at all, then it's going to increase the chances that this individual or whoever has that is going to be at risk for inflammation and or infection as well. Infection that could occur anywhere along the bronchial tree. Okay, smoking is one of the things that makes people more susceptible to infection because the smoke paralyzes the cilia in that mucociliary escalator so that it doesn't work correctly. And then that's where people start getting that chronic smoker's cough. Okay. And then from the trachea, we kind of dissect down and go into smaller and smaller branches of the tree. We go from bronchi to bronchioles. And in the very, very smallest area, the very smallest area is called the alveoli. And the alveoli is actually the functioning part of the lungs, and the functioning part of the lungs is also called the parenchyma. And these alveoli are made of very, very thin, small sacs that are a single layer of squamous epithelium called pneumocytes. This single layer of epithelium allows for our gas exchange to take place. So with that gas exchange, we have oxygen coming in and CO2 leaving, okay? The alveoli, just like the surface area of the nose, has an extremely huge surface area. And the reason why that is because we need a lot of surface area in order to provide this gas exchange that takes place with every breath that we take. Okay, and our body does a really good job of making use of the area that we have by increasing surface area, and we see that in the lungs and the alveoli. We see it in the nasal passages. We also see it in the convoluted folds of the brain as well, where our body just really utilizes surface area to increase that exposure. So when we actually look at the mechanisms of breathing, we have two parts to it. We have an inspiration process, also called inhalation, where our diaphragm contracts. And when our diaphragm contracts, it actually flattens, and that actually causes the intercostal muscles and the rib cage to raise out, and that increases the space in the thoracic cavity. And that increasing of space allows and draws air to be pulled in. Now, expiration is more of a kind of a passive process. Once we've kind of maximized and taken in as much air as we can, then there is a point where the pressure in the thoracic cavity becomes greater than the outside air, and that kind of causes the diaphragm to relax, and then we exhale out the carbon dioxide that we've just exchanged. Okay. All of this is stemmed from the brainstem in the brain. And so the specific parts that we look at that control this, the primary controller is the medulla oblongata. It's considered the breathing control center, and it controls the rhythm and the rate. But a small structure right next to it called the pons plays a part in this too, because it also controls, controls the rate to where the medulla oblongata controls the rhythm and the depth. So they work together to stimulate our bodies to take a deep breath in with every respiratory cycle. That's why brainstem injuries can affect that breathing and actually cause someone to have to be on a ventilator. All right, and so why do we take that deep breath in? Well, because our bodies need oxygen. Now remember, air is actually only about 20% oxygen. There's mostly nitrogen and then some other CO2 is there because that's what we exhale. But oxygen is our primary source for driving our cells mixed with glucose to actually fuel our cells and our tissues. And when we mix oxygen and put it within the red blood cell with the hemoglobin, because that's the protein that binds the oxygen and carries it to our tissues, it's called oxyhemoglobin. Okay, it tends to be very bright red in color. And the flip side of this is when carbon dioxide, once it's delivered to the tissues, we then have a case scenario where carbon dioxide then switches places and then is taken from the tissues and taken up to the lungs to be expired out. And when the carbon dioxide attaches to that hemoglobin protein, it's called carboxyhemoglobin. Okay. Now, when we look at the lungs and how we measure the amount of air that comes in and out, we actually measure these in respiratory volumes, okay? When you look at the amount of air that the lungs can hold, you can actually calculate something called respiratory capacity by kind of adding some of these volumes together. Now, if you look at the book on page 610, it actually gives you a table that kind of goes through these volumes, okay? So just kind of glancing and having a look at that, we'll go through the next slide or two, will give us a little bit more information on that, but that table that we're referring to is on page 610, 28.1, okay? So this is kind of a list of what's there. And so the big things that we'll kind of look at, and it gets a little confusing staring at this, so I don't want you to get too overwhelmed by looking at it. We'll go through it a little bit in class, but what it is guide to show you is that there is different amounts of volume within the lungs, depending on whether we're expiring, inhaling, and what's actually left over with that. And so we have something called a tidal volume. A tidal volume is just an amount of air that's moved in and out in one normal, regular respiratory cycle. Okay, and the volumes are actually listed, kind of average volumes are listed on page 28 on the table on 28.1. These volumes will change depending on your age and depending on your gender. Males tend to have a little higher respiratory volumes than females do just because their chest tends to be a little bit bigger, okay? And so these that are listed on that table are really just averages because males and females do differ. Then we have two volumes, an inspiratory reserve volume and an expiratory reserve volume, okay? And so that inspiratory reserve volume is just taking that tidal volume, whatever little light air that goes in and out with each inspiration, expiration. If you take that tidal volume and you add whatever a forced inhalation is, you get an inspiratory reserve volume. Same thing with the expiratory reserve volume. Whatever your expiratory volume is on a normal, regular cycle, if you force that air out, then you get expiratory reserve volume. Then we have something called RV, or residual volume. That is the volume of air that is present at all times within the lungs. No matter how deep of a breath you take or how hard you try to blow out, there's always a little bit of a volume down in the alveoli. And the reason why that is because if there's no air down there, it can collapse. So the combination of that residual volume or that residual air mixed with surfactant helps to keep the alveoli open so that they don't collapse. Okay, we'll talk about a condition called atelectasis in a little bit. And atelectasis is a situation where for one reason or another, those small alveoli, those small air sacs actually collapse. And that can actually cause the lung to collapse. Okay. Then we kind of travel down a little bit and we look at something called vital capacity. So our vital capacity, which is acronym to VC, is sort of our tidal volume mixed with that inspiratory volume, which is our maximum inspiration, and our maximum expiration. And that's an important an important acronym because we see it down a little bit low. And then we can actually look at the total lung capacity. That's basically the entire vital capacity plus the residual volume that's left over. So that is the total lung capacity of any one given individual. Now the two bottom ones are important because during this class we will be talking about spirometry and peak flow. Those are two of the pulmonary function testings that we'll be talking about and dealing with in this lecture and during this week. And so when we look at something called a forced vital capacity, that's acronym FVC, that is actually what is being determined with spirometry. And so that is the amount of air that you can exhale with force after you've taken a full, deep inspiration. Now, forced vital capacity needs to be done over at least a 5 to 6 second period of time because you need to completely drain all the air that you possibly can out of your lungs minus the residual volume. That never goes away. But that forced vital capacity can give us some diagnostic criteria for people that have COPD and for people that have asthma as well as other chronic lung conditions. Okay. The one below that is called a peak expiratory flow rate. You'll see these acronyms. I think I confused and put PERF. It's actually PEFR. I apologize. Or FEV. So this is basically the greatest amount or rate of flow of air that can be forced out in one quick second. And you'll see this acronym as a peak flow. Okay, and there are different levels to assess that. We have different zones that we use to kind of detect whether or not somebody has, whether or not someone's lung capacity is where it's supposed to be, or whether we're in a danger zone, you know, an intermediate or a threatened danger zone. And we will go into a little bit more depth with this in chapter 49. Okay, so let's go, these next couple of slides will talk about some of the disease processes that can affect the respiratory system. So the first two that are listed here are allergic rhinitis and asthma. And the reason why these are important is because these are actually hypersensitivity reactions to an airborne allergen of some sort, okay? When we're dealing with allergic rhinitis, we're dealing with symptoms that are primarily in the upper respiratory tract, okay? Nose, throat, it even includes the eyes. Our mucous membranes have stationary cells called mast cells, M-A-S-T. And those mast cells can secrete something called histamine in response to an airborne allergen that particular individual views as being not normal. And some individuals will form a hypersensitive reaction to exposure to that. Now, examples of that could be dog dander, cat dander, grasses, molds, pollens, all sorts of different external environmental allergens can actually cause a hypersensitivity reaction. It's very individual because some people can be allergic to lots of different things and other people have absolutely no sensitivity at all to things. And so allergic rhinitis usually manifests with itchy, watery eyes, runny nose, nasal congestion, scratchy sore throat, or maybe a mild cough. And so these are symptoms of allergic rhinitis. And luckily there are certain medications that can be used to decrease the inflammation that's caused by this. Asthma is a very similar situation where you're inhaling that airborne allergen, and instead of just being in the upper respiratory tract, it actually causes inflammation and a hypersensitivity reaction within the bronchial passages. So what happens there is you can get that same kind of excess fluid secretion from the histamine release. You can also get bronchospasm or bronchoconstriction, and that means that smooth muscle around the bronchial areas can constrict. And so that can lead to cough, shortness of breath, dyspnea, and so these can be, because it deals with the exchange of oxygen in and out of the lungs, can be very dangerous, okay? So there are ways to treat both of these, but they can be very significant and have significant morbidity and mortality at times. There's really no mortality with allergic rhinitis, but there can be with asthma. And so adequately controlling these two disease processes is very important. When we're dealing with the peak flow meter, we will be dealing, and actually the spirometry as well. This is because asthma is so common and we see it so frequently. It's one of the disease processes that we can use to assess not only the severity of the illness, but also treatment regimens with both of those modalities. Then we have another condition called atelectasis, and I kind of alluded to that already. That's actually, they call it a collapsed lung, but it isn't necessarily the whole lung that collapses, it's actually the alveoli. And so one of the things that helps to keep the alveoli open and patent and allowing gas exchange is that residual volume of air that we talked about. So if something happens to that residual volume, it can cause the lungs to collapse. The other thing that can do that is if there's an issue with surfactant. And surfactant is something that is created by the internal layer of the alveoli that actually helps to increase the surface tension and keep that keep those alveoli open. And we'll talk about something briefly. One of the things that we'll talk about a little later is respiratory distress syndrome, and that's a scenario where premature babies haven't had the opportunity for their body or their lungs to produce the surfactant, and so they end up having problems with birth because of collapsed lungs. Okay. The other thing that can lead to atelectasis is a number of different if you actually puncture the wound, puncture the lung, certain infections like pleuritis or pleurisy, post-operative, if someone's been laying for a long period of time or is sitting and not expanding that lung, taking deep breaths in, that can also lead to atelectasis as well. Okay. Then we have bronchitis. Now bronchitis is basically an inflammation. Itis is inflammation, broncho means the bronchus. So it's basically lung inflammation. It can be from a number of different causes. We can actually see acute cases of bronchitis, which are oftentimes a situation with like some lung inflammation after a cold or a flu or a sinus infection, something like that. The bronchus can become secondarily inflamed. And then there are chronic causes of bronchitis, which we actually see in COPD. Okay, that can be from some sort of chronic irritant like smoking. All right, those people that have chronic bronchitis have a higher incidence of pneumonia and higher incidence of getting more severe lung infections. Generally, if something is acute, they used to treat bronchitis with antibiotics, and they've kind of found that it's more of an inflammatory response as opposed to necessarily being an acute infection when you're dealing with an acute situation. Chronic cases oftentimes do need antibiotics, but acute cases they're trying to treat with anti-inflammatories, cough suppressants, and sometimes even bronchodilators, and trying to have it be one of those areas where we're not over-treating with antibiotics. Okay. Then we have COPD, which is chronic obstructive pulmonary disease. And this is a group of disorders that basically limits airflow to the lungs. Due to that chronic damage for whatever the irritant is, it's usually smoking. But what happens is the alveoli deteriorate. They kind of become enlarged, what actually decreases the surface area of the alveoli. And leads to a series of signs and symptoms that go along with that. The two most common COPD-related illnesses are emphysema and then chronic bronchitis, which we just alluded to. So what is emphysema? So emphysema is basically a chronic, irreversible condition that is generally caused from smoking. Okay, the alveoli start to deteriorate, which decreases the ability of the lungs to exchange that oxygen in and CO2 out, and it also can paralyze the cilia of the mucociliary escalator. And so what generally happens is that we wind up getting a continual chronic deterioration of the lungs to the point where we can't exchange gases anymore. Okay. Then we have then we have the flu. And so influenza is what we particularly call the flu. Now the influenza is generally a viral infection. It could be listed in an area of infectious diseases because it's a flu or a viral infection. However, because there can be some respiratory manifestations, oftentimes there is kind of a chronic dry, not a chronic, but a dry cough associated. There's usually fever, body aches, sore throat. Sometimes the flu will actually cause gastrointestinal symptoms too, like vomiting and diarrhea. But because there are certain age populations, people that are immunosuppressed, the elderly, and the very young, those particular subpopulations of patients are more at risk for developing a pneumonia, which is actually an infection in the lower respiratory tract. And so because of that, they put influenza here. Now, obviously, that's one of the reasons why we really encourage the flu shot. However, there are quite a few different types of influenza viral strains. There's influenza type A, influenza type B, para-influenza, the swine flu. There's a number of different flus. And so our flu shots oftentimes cover 3 or 4 of the strains, not always all of them. And so that's why it is still possible to get the flu even if you have a flu shot, but that's primarily because the flu shot does not cover every single strain. They attempt to cover the more common strains that they're finding each year. But of course, it is still possible to get a cold or a different flu strain that wasn't within the flu shot, even if you get that, even if the vaccine is administered. And so it's important to realize that it doesn't prevent everything, but it does prevent and work if you actually are exposed to one of the viruses within that strain. Okay. Then we have something called laryngitis, and so itis, once again, is inflammation of, and laryngo refers to the voice box. So this is basically a prototypical situation where someone gets inflammation of the vocal cords. And so this can happen from a number of different reasons. It could be a bacteria or a virus. More commonly, if it's short term, it's just a virus. But there can actually be case scenarios where there are polyps, excessive screaming, yelling, singing, anything that puts a strain on the vocal cords can also cause that inflammation to occur. If it's just a viral infection, it usually will pass in a couple of days with some anti-inflammatories and voice rest and warm fluids. Someone with chronic laryngitis, you might have to start looking at some sort of issue with the vocal cords, maybe some sort of polyp or cancerous condition with that. Another word, I guess the other word that goes along with that is hoarseness. You'll sometimes say my voice feels hoarse, and the medical term for that is dysphonia. Okay, we have a few more to go through. I'm not going to go through all of them. I am going to hit lung cancer. There's a picture, figure 28.6 kind of shows the difference in the book between a normal looking lung and a lung that is infiltrated with cancer. And so lung cancer is probably the most lethal or has the highest mortality rate of all the cancers in the United States. We do have others that are close, but this one usually tops the charts every year, and the majority of them are due to smoking. The book goes through some of the classifications and some of the stages. I'm not really going to go into that too much. There are some rare forms of cancer that don't involve smoking, but the large majority do, okay? And so obviously it's one of those cancers that we could probably prevent the majority of the cases of just by not smoking, vaping, any kind of inhaled toxin, okay? Then we go to something called pneumoconiosis. And pneumoconiosis is basically a lung disease that's from environmental or occupational dusts. And so the 3 categories of this are anthracosis, which is black lung disease from coal inhalation, asbestosis, which is from the inhalations of asbestosis particles, and silicosis is the inhalation of silicone. And so Environmental Protection Agency has gone through, and we've had a very large increase in procedures and policies to protect workers from these particular lung diseases. And so it's not something that will really hit someone the first day or 2 or month or year, but with 15, 20, 25 years of exposure, eventually those particles take over the lung, keep that person from being able to exchange oxygen or gas exchange, and eventually lead to lung disease and lung collapse, not lung collapse, but just the inability to exchange gases. So luckily we have made better strides over the past 20, 30, 40 years with this, but we do still see these environmental diseases occur at times. Okay. Then we have pneumonia. Now, pneumonia can be an inflammation of the respiratory tract, but usually pneumonia is due to some sort of infection, whether it's a virus, whether it's a bacteria, or even a fungus. Most people that have intact normal immune systems don't see fungal pneumonias, but people with HIV do see what our body normally keeps intact. Someone with HIV and an altered immune system or suppressed immune system can be subject and susceptible to fungal types of pneumonia. So the more common ones are viral and bacterial. Sometimes it can be difficult to assess just on an x-ray whether something is viral or bacterial. You oftentimes have to look clinically. The degree of the fever, the degree of the respiratory compromise can sometimes give you an idea. Pneumonia, generally, if it's bacterial, needs to be treated with antibiotics. Okay. Then we have something called a pneumothorax. Pneumo means air, thorax is in the chest, and so this is where we have some sort of injury some sort of injury between the lung itself and the actual wall of the thorax. And so if something happens, like a stabbing wound or a knife wound or stab wound or even a gunshot wound, if something penetrates into that air, it causes air to get inside of there and then puts pressure on the lung, and then you can't breathe, you can't take a big breath, and that's extremely dangerous. That's when they have to go in and put a chest tube to release the air to come out. But that is usually due most of the time to some sort of trauma to the cavity or somewhere in that area between the lung and the thorax, the thoracic cavity. Okay. Then we have a situation, something called pulmonary edema. Pulmonary edema is where we actually, it's common to occur usually when we have problems with the heart. When we have the heart not pumping properly due to either right-sided or left-sided heart failure, where one side, for whatever reason, due to chronic disease or a heart attack, doesn't contract the way it's supposed to. And so what happens is we actually see fluid start to build up in the lungs. And so the spaces between the alveoli, between the capillary wall and the alveolar wall, there's a very teeny tiny interstitial space there. And when the left side of the heart does not pump appropriately, then the fluid or the blood will back up into the pulmonary system, and that fluid will then leak into that interstitial space, and it gives a very wet sounding quality to listening to when you're listening to the lungs with a stethoscope. And so it almost gives you a kind of a crackling wet sound. Okay, that can be very dangerous because obviously if there's fluid in there, the gas exchange is not going to go across the fluid. And so giving people diuretics to get rid of the excess fluid, giving those patients medicines to help their heart contract more efficiently is important, because pulmonary edema is extremely dangerous. Okay. Then we have a pulmonary embolism. So remember, we have different clots in the body. We have a thrombus, which is a stationary clot, usually a buildup in an artery or a vein due to excessive cholesterol levels in the blood. Then we have embolisms, which are traveling clots. And so this is generally a situation where someone has a thrombus somewhere, some sort of a stationary clot, and then it breaks off and starts to travel through the system. And when that happens, that clot can lodge in a small artery or vein elsewhere in the body. And so a pulmonary embolism is when something breaks off and travels to the lung and then occludes an artery in the lung. And if that happens, it can cut off the blood supply, and then that part of the lung can die. Okay, and so it's important to make sure that when people are post-surgery that they wear compression stockings, because that's a common time for these pulmonary embolisms to occur. Anytime you're sitting with your legs bent for prolonged periods of time. People that drive trucks or people that are in airplanes for a long period of time tend to be kind of a high risk for pulmonary embolism as well. All right, and so this is the last set of diseases from the book. Respiratory distress syndrome, is acronymed RDS. We actually see this common in premature infants. And so if that infant is delivered before a certain point, and it can vary, any infant before 35 weeks is at risk for this, but it does tend to be more common in the 28 to 32 range. And so what happens is they haven't had enough time to develop surfactant. And if that happens, then when they're born, their lungs can be collapsed, and that can lead to obviously a respiratory distress syndrome. If they can keep the baby in utero for a period of time, there are some injectable medications that can be given that helps increase the rate of surfactant development during preterm labor. But if things go too quickly and that can't be done, then these patients can be born with a respiratory distress syndrome. Sinusitis, we kind of talked about that a little bit earlier. That's an inflammation and or infection in the lining of the sinuses. Usually it's due to either chronic allergies or an underlying upper respiratory infection like a cold. And then when that virus is in the system, there's inflammation within those passages. And then if that inflammation's there for too long, it can then allow bacteria to get inside and cause an infection. So oftentimes sinusitis, if it's severe enough, will need antibiotics, but it's important to make sure that we control allergic rhinitis, because if you have allergies, you're at an increased risk, but if you can control that, you'll decrease the sinus infections that can happen post, or with allergies. Obviously with colds, it is a risk factor that does happen sometimes, and so just making sure that you take care of that cold and utilize all the prophylactic things to try to combat that. You can sometimes decrease the sinus infection. There are some people that tend to be more prone to them. A deviated septum, issues with the sinuses can have certain patient populations that are more susceptible to sinus infections. Then we have sudden infant death syndrome, and that's also acronymed SIDS. And SIDS is basically where a child, for no apparent reason, ends up passing away during sleep. And the book talks about it going up to a year. I was always kind of told 6 months. There's probably been some cases that are post 6 months, but 4 to 6 months is kind of the more common time frame. The book also goes through and kind of talks about some of the things that make a child more susceptible to this, and then some of the things that you can do to prevent it, laying the baby on their back. If there is a high-risk child, sending them home with an apnea monitor can help decrease this. Making sure that they are breastfed, making sure immunizations are used, sleeping on the back, avoid overheating. Babies don't need to have great big huge sheets and comforters on there. They just need something that keeps them encompassed and safe, but they don't need great big huge bedding, no soft toys, no comforters, because those increase the risk as well. And then also when their infant is in the environment of smoke, so secondhand smoke can increase that as well. So the book kind of goes through and talks about those. The last two things that are on the list are tuberculosis and upper respiratory infections. So TB is an infection caused by the bacteria Mycobacterium tuberculosis. It's a very difficult bacteria to combat. It tends to be a respiratory, pass through respiratory droplets and inhaled into the respiratory tract. It does have the capability of actually migrating out and going to other parts of the body, but generally it's considered a pulmonary infection or pulmonary issue. The reason why it's so significant is because there is a very high incidence of drug-resistant bacterium. The Mycobacterium have an extremely thick, waxy cell wall around itself, and so it makes it extremely difficult for antibiotics to penetrate that wall and actually kill the bacteria. Most people that have active tuberculosis need to take 4 to 5 medications for a year in order to get rid of it. We don't really see any other bacterial infections that need antibiotics for that length of time. So it's very difficult to treat, and it's very, very contagious. If somebody is actually positive, the public health department comes in, surrounds them, puts them in isolation and quarantine. It's a very dangerous bacteria because of that. And then anyone that has a suppressed immune system, HIV patients, are definitely at a higher risk for this infection. That is one of the reasons why every single year healthcare providers need to have either the two-step PPD or the quantiferon gold test. Okay, and that's a blood test. And those two things can detect whether or not you've been exposed. Okay. And there is a difference between exposure and active disease. People can be exposed and have it be dormant and not doing anything and quiescent, but then there can be a time in life when it becomes activated because that person's immune system drops, and then it can turn into an active phase. And so not only do we have to have multiple antibiotics to treat an active phase, if someone is in the inactive phase, there are certain patient populations that we'll also treat with an antibiotic called INH to try and get rid of it or to decrease the risk of ever having that patient become positive. Okay. And then lastly, we have upper respiratory infections. Those are called URIs, basically also called the common cold. You get a cascade of symptoms that are runny nose, nasal congestion, watery eyes, cough, feeling a little under the weather. Usually you don't have body aches and a fever with a common cold. That kind of differentiates between a flu and a cold. The common cold is part of the rhinovirus family. Rhino means nose. And there's more than 150 strains of that virus, which is why it's very easy to get colds over and over again. And even though you might go, gee, I've had 50 colds in my life, even though you've had one, you're still susceptible to a different strain. And so because there's so many of them, that does tend to be why it's probably the more common infection that people will get. It's important to know when you have a cold because antibiotics do not need to be taken for the common cold. And this is a huge issue in primary care where people come in and they've been sick for 2, 3, 4 days, and then maybe their mucus starts to get a little bit thicker and a little bit more colored than it was, and everybody after 3 or 4 days wants antibiotics. And it's been a very large undertaking to try and educate the public on the need for giving a cold its time and its due time to go away and not always feeling like we have to throw antibiotics at something. The minute someone's mucus becomes colored, they think they need antibiotics, and sometimes it does. If somebody had a cold for a week, week and a half, and then suddenly they started getting a productive cough, low-grade fevers, difficulty breathing, it can sometimes turn into a bronchitis or pneumonia. So there are times where it does need to happen, or antibiotics do need to be given, but it's really important that we're very, very strong with education, with patients, and with healthcare faculty to let them know and be able to educate everyone on not rushing to antibiotics every time they have upper respiratory infection. Okay, so that's going to do it for this chapter. I'm going to go ahead and log out, and I will see you in the next video.